Hi, this is James Warda, Senior Director of Marketing and Communications with the Home-Centered Care Institute. I'd like to welcome you to another episode of HCCI Conversations with, where we're talking to key stakeholders across the industry. Today we have a great episode. I want to welcome Tom Koutsoumpas and Dr. Eric DeJonge to the show. So welcome. Hi, Tom. Hi, Eric.
Thank you. Thank you so much, James.
Tom, could you take a minute and just introduce yourself and tell us a little bit about your organization?
Sure. Thank you. And thanks again for the opportunity. So I'm Tom Koutsoumpas. I'm a co-founder and co-chair of C-TAC, the Coalition to Transform Advanced Care. C-TAC was an organization started a number of years ago. My co-founder, Bill Novelli, former CEO at AARP, and I created an organization to focus on advocating on behalf of people with advanced illness, creating new models of care, and really hoping to help create a better system of care for people through that aging advanced illness time of their lives. I also started the National Partnership for Hospice Innovation, which is a not-for-profit community-based organization of 70 of the nation's largest not-for-profit hospice and palliative care providers. And my third role is I'm CEO and president of Capital Caring Health in the Washington, D.C. area.
So you have a lot of free time.
I have a good amount of free time.
Thanks. Okay, Eric, thanks for joining us. Can you tell us a little bit about yourself, your title, and what you do too?
Sure. So I'm Eric DeJonge. I'm a geriatrician and internal medicine doc, primary care and training. And I'm the chief of geriatrics at Capital Caring Health in the DC, Maryland, Virginia area. I got really interested in geriatrics and primary care in my residency in the early 90s at Johns Hopkins Bayview, where I was assigned 10 patients in kind of East Baltimore by my mentor and said, you got to go make house calls on these people. And I learned how to make house calls in East Baltimore and have really never looked back. I find making home-based visits really helps me take better care of patients and families, and it's a lot more rewarding for me than sitting in an office.
Well, thanks, Eric. And it's hard to have any conversation today, so we'll just jump right in without talking about COVID, right? So I really wanted to ask for both of your perspectives, and from your organization's perspectives on just generally what you are seeing with the pandemic. So can you give us your perspectives on it, Tom?
I tell you, it's certainly been a challenging period, but it's been an enlightening period in terms of learning about what's important, about best practices, about how to really change the way we care for people. And it's interesting to me in my observation, and I'll be interested in hearing Eric's observations about this as well, but I think what it's really underscored is the work that we've been doing together to focus on the importance of the home, of caring for people in their homes, using technology, and really understanding how we can go to the patient and family and care for them in their setting, in their home setting, or in wherever they're residing, in a much different way than we've done before. So it's really taught us the value and importance of that sort of model, of which HCCI and we have all been working towards for such a long time.
So Eric, can you tell me a little bit about what you're seeing, with COVID-19? Anything that's surprising that's, staying out?
Yeah, I think with the onset of COVID-19, there's been a even greater emphasis on the value and power of home care medicine. I mean, I think we've been seeing patients for house calls, primary care, and home hospice, but also seeing a lot of patients in the nursing homes and hospitals in the area. And I have to say that the level of safety and ability to care for people, both for staff safety and for patient and family safety, I think is higher in the home than it is in group setting. So the value of seeing people in their home, whether it's in person or via televideo, I think has really been emphasized yet again. And I would just finally say it's really forced us to be flexible with staff kind of assignments, flexible with geography. We've actually started to open up our geography because now we can do televideo visits and not have to drive all over the place. So in some ways, it's made us a bit more efficient, especially on follow-up visits and urgent visits.
What would you say to someone who would say, oh, okay, well, then maybe we don't need to get into the home. Maybe telemedicine is enough. How would you answer that?
Yeah, we've talked about that a lot on our teams, and what we have found is that the initial visit in particular, and I just came from one this morning here in the DC area, a 90-minute plus visit, talking to the aide in the home, the wife, the patient, a daughter who was on FaceTime from the West Coast. And doing that initial visit is particularly important to be in person, to develop trust, to know the home environment, and really get the care off on a good start. After that, I think that the degree of televideo and in-person for follow-up visits, that can be a hybrid. I think there are some visits you have to really be there in person to assess how sick someone is, or if there's a major psychosocial or emotional situation, you want to be there in person. So then I would say roughly you could do 50-50, or 1/3 in person and 2/3 televideo for follow-up visits. But I think that in-person visit initially is crucially important for the relationship with the patient.
This is really for Tom, for you and Eric. Let's talk a little bit about all the changes that have come out from CMS, right? Especially around telemedicine, and how much has that helped you both do what you need to do, both do your work?
Sure. Well, certainly the easing of regulations around telehealth and the ability to provide care that couldn't be done through telehealth before has been tremendous. I mean, the loosening of the regulations and the ability in hospice, for instance, recertification can now be done through telehealth as opposed to having to go out and see the patient in person. So that is certainly changed the dynamic. It's created a safer opportunity and environment for the patient.
Yeah, I think I would also really commend CMS in some ways. They've acted very quickly in a lot of flexibility, remarkable speed to change regulations that allow us to keep taking care of people. The telehealth billing and coding is one. I would highlight that they cleared nurse practitioners and physician assistants to certify to do home health. So that makes home health care more accessible to more people who need it. And there's been a kind of a speed with which they've acted that the government is not always known for. So I think CMS deserves some credit for making those changes as quickly as they have.
Yeah, I would just add to that as well, Eric. I'm glad you brought that up. It's been tremendous, actually, in a very short period of time to act as quickly as they have to address these issues and to really get through a lot of complicated regulation and ease that in a way that makes it very effective very quickly has been pretty tremendous, I think.
Getting back to the CMS changes. So obviously, we've had a lot of changes that have been supportive, but as the pandemic resolves over the coming months or however long it is, do you foresee those changes going back?
Yeah, I think there may be some going back, but I think there'll be a very methodical and thorough review of what's worked and what hasn't worked. And so my hope is that the success of the use of technology and the use of the approaches that have been taken as a result of won't just automatically go back, but that there'll be a real review of what's working, what's not working, and really focus on continuing to allow those things that do work well to continue.
And James, I would add that I think what CMS might worry about is people are going to game the system and just run up a lot of bills and not do appropriate care. And what I would suggest to CMS is hold health providers accountable for results. So pay them not based on every single box that you check, every single televideo visit that you do, make that allowed, but really reward providers based on their cost savings, on the quality of the patient and family experience, and shift the value-based payment faster than kind of the old fee-for-service system, which can always be gamed by people who want to make extra money.
Yes, exactly. And I would agree completely, Eric. And I think, in addition, and to go back to one of the questions you asked earlier, James, there is no substitution ultimately for, in-person care. I mean, the person-to-person touch and, the issues around social isolation that we're seeing that are really developing in a very serious way, while some of them can be addressed by technology, it's no substitution. So I think you have to carefully look at the balance. How do you make sure that you continue the direct care, the in-person care, the human-to-human touch, which there is no substitution for, no matter how good your Zoom video is. And those are the kind of things that we'll have to carefully assess and make sure that that balancing occurs.
Do you see any other areas of healthcare changing, not just the CMS piece, but because of the pandemic? So the way that teams work together, collaborate, hospital being the center of the system, anything else that you would see changing?
Yeah, James, great question. Actually, I think there's several areas that I have both some hope, but also some concern about. I'm concerned that a lot of patients right now are having their other medical issues not attended to because they're isolated and trapped, say, in an assisted living facility where they can't have providers come in and see them. These are things like wound care, loss of vision, kind of things that are happening, but it's hard to get them adequate access to care. So I think we're gonna have to figure out how do we, if this goes on for a year or two at least until a vaccine is available, how do we get more routine and urgent services available to folks for non-COVID illness? That's the main concern that I'm running into right now, is that I worry that sometimes those other illnesses are progressing to a later stage because we're not seeing them as often as we should.
So again, how do we need to make sure we've got enough providers and practices and that they're educated and trained to be able to do that. Do you see any additional types of education needs or being needed to prepare our providers and practices to do that?
That's a great question, Jim. I think the one thing that we work on a lot in our team is kind of really learning how to work within an interdisciplinary team. And that's not something we learn in medical school very much. How do you teach doctors, NPs, nurses, social workers, and all the members of the team to really respect each other and work in a horizontal fashion so that there isn't kind of doctor's orders, but it's everyone kind of communicating on a regular basis and putting all of their skills together to the same goal. I think that's an area of training and work that is kind of natural for the hospice world, as Tom mentioned, but I think moving it upstream to the general clinical care model is the next step.
The past few months have been pretty incredible for everybody, right? So have you seen any stories in your own, in your organizations? What's been surprising to you? Maybe something you learned about yourself during the last couple months?
Well, I'm going to tell a story about a patient, again, with a few details changed for privacy, but about a month ago, just as the pandemic was kind of getting full steam, we got a call about a 95-year-old house call patient of ours who had all the classic symptoms of COVID-19 at home. And we had to do both televideo, telephone, some in-person visits with protective equipment. We did the testing at home. We got the oxygen quickly at home because Medicare had loosened up the rules on that. It's now a month later, and that 95-year-old person is actually doing well. So you can actually manage COVID-19 with intensive interdisciplinary and technology at home, as well as the in-person touch, supporting the family who had to be quarantined, and folks can come out on the other side. So there's a high mortality rate. It is very scary, but with really careful, safe care at home, that person was protected and she came out the other side.
That's a great story. I would also add, just in general, the stories from our front lines, from our caregivers, from Dr. DeYoung and his colleagues who are out there in the homes visiting our patients and families. It's extraordinary. We've had absolutely no hesitation from all of our staff to make sure, in fact, that the drive has been forceful to make sure that they get to the home, they care for the patients, they have all the appropriate PPE. One other story I would tell, which was really touching to me the other day, we care for people from at all ages and with, of course, all kinds of conditions. And we had a family call recently whose 17-year-old has a brain tumor and had been in the hospital for a long period of time. And the family had been cut off to being able to visit the child who was progressively getting worse. and they asked us how quickly could we help and move the child back into the home setting and surround them with the right kind of care. Within about 2 hours, we were able to take the child out of the hospital setting. The parents hadn't seen the child for quite a while because of the rules that they had implemented. We got them home, and we're still caring for that child with their family around them at home. And what an amazing story, what an amazing thing to be able to do, and think about the impact that has on the child, the parents, and the family. It's just extraordinary, and the staff. So those are the kind of things we live for.
That's very powerful. So that's taking it to the individual stories. Wanted to pull back a little bit. We've heard a lot about the C-TAC, the Coalition to Transform Advanced Care moonshot goal.
Yes.
I was going to ask you, Tom, and could you bring us up to speed on the moonshot goal? If there's what it is, if it's changed because of the pandemic, anything else?
Yeah, I think the original goal was a lauded goal of assuring that over 12 million people were cared for who had serious and advanced illness by the year 2030 in a very comprehensive and organized way, creating a very high quality of care, and really making sure that all the pieces are coming together to achieve that. I think, and when I've talked to my colleagues at C-TAC about, I think we have to advance the goal from a timing perspective. And I think the COVID opportunity has underscored that we need to move more quickly, that we need to put in the right models of care, the right levels of support, and aggressively change the moonshot from the 2030 goal to a much sooner goal to make sure we can achieve this important goal, which I think will be achievable as well, because I think there's so much now focus, as we talked earlier, about embracing home care, embracing technology, embracing ways to make sure that we can implement new approaches to care for people at home across the board, with terminal illness, with advanced illness, with serious illness. And I think we'll be able to achieve that. So in my view, it's enhanced the opportunity to pursue the goal more aggressively.
So Tom, HCCI has also worked with Respecting Choices, one of the organizations affiliated with C-TAC.
Yes, yes.
In the past. Can you tell us a little bit about what you're seeing around advanced care conversations and Respecting Choices?
Yes, absolutely. And thanks for that question. I think it's the pandemic and the issues that we're facing, and the fact that people are in hospitals dying alone, all of those things have underscored the urgency around advanced care planning, advanced directives. And I'm proud to say that Respecting Choices is really the gold standard of that. They have worked for many years to implement the very highest quality approach to advanced directives. And I think this pandemic has underscored the need to continue to, again, aggressively push for adoption of advanced directives and advanced care planning.
James, I do want to just suggest to add to what Tom just mentioned about advanced care planning. I think that's been a major silver lining, if you will, of this pandemic, and that millions of people now know what it means to be put on a ventilator.
Yeah.
Most people never even really understood that before, and the kind of suffering and when it might be appropriate. And I think people are making decisions about that in a much more informed and thoughtful way so that they can stay at home, because literally, other than the ventilator and ICU care, you can do most everything you need to at home for this illness. And so unless people want a ventilator, they are choosing to stay at home, which I think is often a more dignified and kind of peaceful place to have care. And we are finding, at least with several of our patients, that people are having a better outcome by being at home if they're not in that ICU level of illness.
So last question, HCCI does a I Heart House Calls campaign, and we always finish these interviews with that question. So can you both tell me why do you love house calls?
Well, I love it because I think it's where care should be delivered. I think that being able to go to the patient, when many years ago, my surrogate grandmother and my grandfather were doctors. She in particular was well known. She was actually President Kennedy's physician, and she used to visit with me about what she thought the most important and the best kind of way to deliver care is in the home. And this is, 30 years ago, 40 years ago. Home is where it should be. Home is where you live and where your heart is. And to be able to go into the home and care for people in their home, making it easier, supporting them in a loving environment, not a sterile waiting room or a sterile ER or hospital setting, is such a difference. And so there is no place like home. And we actually use that line at Capital Caring Health in our materials because it's important from our perspective. So with that being said, that's where care should be, and that's why we love it. If I could just say a personal note as well, I have a great affection for HCCI. Dr. Tom Cornwell, we know and love, and we all met through Tom many years ago. The work that you all do is just extraordinary and has brought so many of us together to focus on how to do this. And so I just want to thank you as well for the extraordinary work that you do to really drive this forward.
Thank you. Thanks, Tom. Eric, how about you?
I think I love house calls because of the family pictures. I get to go to the home and I see all the pictures of the patient at every stage of their life, and see all the people who are important to them in their life. And so I love the history of learning about my patient, but not just because it feels good, but because it then allows me to take better care of them. Because if I understand their culture and their family and their home environment, I have information that allows me to make better decisions about their medical problems, about their end of life when it comes to that. And I'm kind of a guest and a part of the family in doing so. So it's tremendous, honor to be in that situation, which I honestly don't feel when patients come into the office.
Well, I wanted to thank you, Tom. Thank you very much for joining us, and Eric. Obviously, a lot going on, but thanks for taking some time out to do this.
Well, thank you. It's really a pleasure. It's been an honor, and really appreciate the opportunity.
Thank you, James.
Thanks. And thanks to you for watching. Really appreciate it. And we'll see you on the next episode of HCCI Conversations with. Have a really good day. Bye.